we had managed at our center. So this index case is a 54-year-old male. He had recently got his full checkup done. The basal metabolic profile shows presence of hypercholesterolemia and pre-diabetes. He saw a physician last month, and he started him on lifestyle modification. So he basically presented to a primary health center. He had a history of playing 3 sets of badminton before the presentation. He had complaints of epigastric discomfort, which basically he meant कि gas हो रही है. Feel of nausea, mild retrosternal pain. On initial evaluation, his pulse was 86 per minute regular, blood pressure 122/86, saturation was normal at room air. However, diaphoresis was present. So this brings us to a very important question as what are angina equivalents? Angina equivalents are described as breathlessness, pain anywhere other than the precordium, presence of diaphoresis, extreme fatigue, epigastric discomfort, nausea, vomiting, and syncope. These are a few atypical presentations of acute myocardial infarction which may occur with a predisposition to the female population and in elderly and diabetics. So a high index of suspicion is always to be maintained while we deal with such angina equivalents. So this was the initial ECG that was done in the primary healthcare center. So in this ECG, if you see, it is a ECG with a normal sinus rhythm. However, there was a subtle increase of ST in the inferior leads. And if you see, there was a concomitant ST depression in the lateral lead. So this could be a normal variant, or this could have mimicked a ongoing ST elevation acute myocardial infarction. So one single ECG is never good enough to approve or disprove a diagnosis of an acute myocardial infarction. The patient was allowed to be held at the PHC and a repeat ECG was requested. If you see the repeat ECG, there has been a subtle increase of ST elevation in lead 3 as well as in lead AVF. If I go back to the previous slide, if you look very carefully, the ST elevation in lead 3 is at least 1 millimeter. Even in AVF, the next of course shows that there is greater than 2 millimeter ST elevation in AVF, and same thing goes for lead 3. The ST depression in AVL persists. Henceforth, so we come to the question that what is actually an ST elevation myocardial infarction? An ST elevation myocardial infarction is defined as an ST elevation in of greater than 2 millimeters in the anterior chest lead and greater than 1 millimeter in contiguous limb leads. So over here the contiguous limb leads 2 and 3, there was greater than 1 millimeter of ST elevation along with presence of angina equivalents. So the management of the PAC, a loading dose of aspirin 300 milligram to be chewed and then to be swallowed, clopid 600 milligram per oral stat, and a statin of atorvastatin was loaded 80 milligram. Subsequently, the patient was evacuated to a level 2 hospital of ours where the initial ECG was done. Again, if you look, there has been no certain dynamic progression of the ST elevation. The time taken by the patient from PSC to our hospital was roughly around 20 to 30 minutes. However, the dynamic changes of the ECG were not that subtle. But if you look very carefully in this ECG, if you look at lead V2, there is an ST depression. This is a hallmark of a ST elevation MI being accompanied with a right ventricular MI. So over here, when there was a ST elevation in lead 3 which has been greater than ST elevation in lead 2 along with a concomitant depression in the lead V2, this was suggestive of a right ventricular MI. So how do you diagnose a right ventricular MI? You take the right-sided lead. The right-sided lead was taken. However, there was no significant changes found except that RV4 had a ST elevation of nearly around 0.5 millimeter. So there was still a dilemma. So we come to the question as how to place a right-sided chest lead. In the right-sided, when you are trying to achieve and look at the right ventricle and you try to place a right-sided chest lead, what you do is you place the first lead, that is the V1, on the fourth left parasternal area, followed by V2 in the fourth right parasternal area. Subsequently, V3, V4, V5 and V6 are placed. This is just a ECG for understanding purposes that these leads were placed on the right side of the patient. This also shows a right-sided MI in which right ventricular MI in which, if you see very closely, this is the in this ECG the ST elevation in lead 3 was greater than the ST elevation in lead 2. Along with that, there were concomitant ST depressions in lead 1 and AVL. The ECG for representation purposes also show concomitant ST elevation in the right-sided lead, which is greater than 2 millimeters in V2, and of course if you can see, they are all elevated from V3R, V4R, V5R and V6R. So this patient definitely had an RVMI without doubt. Just for the information purposes, as how to place a left-sided posterior or high lateral leads. High lateral leads are placed in the fifth intercostal space, V7, V8 and V9. V8 is placed just in line with the spine of scapula, and V9 is placed on the left paraspinal line, and V7 is placed somewhere in between V8 and V6. So this is how you place left-sided chest leads or high lateral leads. So coming back to our index case, the pulse at the ED department 88 per minute regular, BP 100 by 60, JVP now was increased. However, there was no Kussmaul's sign, no LVS3 was found, no bibasilar crackles were heard. So we come to the question as to what are the hallmarks of a right ventricular MI. Right ventricular MI always comes with hypotension, bradycardia, and the JVP will be increased. There may or may not be Kussmaul's sign. However, bibasilar crackles along with hypotension is a very definitive marker for right ventricular involvement. Absence of bibasilar crackles with hypotension. A bedside 2D echo was done which showed RWMA of the right coronary artery territory and a mild TR was present. Patient was initiated on supportive medications. Injection morphine was given. Now, in cases of MI, injection morphine is not only to be used as a analgesic, but over here morphine is being used as a vagolytic. It not only decreases the tone of the blood vessels, but it also brings down the tachycardia caused by vagus. He was put on LMWH, and finally, in order to bring the heart rate down and to order to bring the work of heart down, 2 into IV metoprolol were given 10 minutes apart to bring the heart rate to 66 to 70 beats per minute. So after having ruled out contraindications to thrombolysis, the patient was thrombolized with tenecteplase 40 milligrams. The success of thrombolysis was noted on the cardiac monitor. Very shortly after he received thrombolysis, about half an hour later, we saw AIVR occurring. There was relief of chest pain. Along with that, the ST elevation in the inferior reed started settling down. However, 30 minutes later, he started complaining of a new kind of precordial discomfort. Pulse 58 per minute. However, the rhythm was irregular. BP dropped down to 78 by 54. JBP was raised. Kussmaul signs became present. IV fluid was started at 100 ml per hour and anxiolysis was given. The fresh ECG post tenecteplase showed, if you look at this ECG, if you look at lead 3, the ST is not so much. The AVF has the ST elevation in AVF has started settling down. However, in the leads 2 and lead V1, if you see, there is sawtooth pattern P waves floating around on the entire baseline. There is sawtooth pattern P waves, and the rate, the RR interval has become variable. So it shows an atrial flutter with variable conduction. So he had also developed a very unstable heart rhythm. So we waited for the heart rhythm to settle down on its own. But however, with the presence of hypotension and an unstable cardiac rhythm, he could not have been shifted out from our center to a PCI capable center. Hence, the decision was taken to DC cardiovert him. He was sedated with propofol and fentanyl, and a synchronized DC cardioversion was carried out with 100 joules of shock. So what is synchronized cardioversion? Synchronized cardioversion is given the heart muscle is shocked with more than normal potential in the absolute refractory period of heart. So the absolute refractory period of heart starts with the onset of the QRS complex, and it is till there in the end of the R or the S complex. So during this absolute refractory period, what is synchronization? The defibrillator synchronizes it with the peak of the R wave, and after the peak of the R wave is over, it shocks the heart. It stops the heart for the moment so that the next impulse can be taken over. So this is what is the difference between a synchronized cardioversion and a defibrillation. In defibrillation, you need not be bothered. You are already having a pulseless electrical activity, so you need not be bothered about what state or what cycle or what cardiac cycle is going on. You just have to deliver a shock anywhere in between so that you get a normal spontaneous rhythm of the heart. ROSC can be achieved. In over here, if you see in atrial fibrillation or paroxysmal supraventricular tachycardia, the heart has to undergo a synchronized cardioversion. The peak impulse or the peak electrical shock delivered to the heart has to be exactly be matched with the peak of the R wave. And that's how you cardiovert, and now you see after the DC shock has been delivered, the rhythm has been converted into a normal sinus rhythm. So this was the ECG post DC shock, and if you see now more prominence of the effective thrombolysis has already come into play. You see the ST elevation has already started slowing down. There has been no S wave formed. However, there has been a change in the QRS complex of lead 3 as compared to the initial ECG. The V2, the ST depression in V2 has settled down. So this was the final ECG before the patient was transferred to a PCI capable center. So now I come to the question as what are the causes of ST elevation in ECGs? What are the other causes of ST elevation in ECGs? You can type the answers in the comment box. Please type the answers in the comment box. So ST elevation in ECGs can not only be seen in myocardial ischemia. The various other causes include Takotsubo cardiomyopathy, post-myocardial infarction. The ST elevation just shows a presence of a ventricular aneurysm, acute pericarditis, normal variants like early repolarization syndrome, left bundle branch block, acute pulmonary embolism, Brugada patterns, use of antiarrhythmic drugs, DC cardioversion, hypercalcemia, hyperkalemia, hypothermia, and non-ischemic myocardial injuries like myocarditis, tumors invading heart, and trauma. Now, what are the causes of elevation of cardiac troponins? The cardiac troponins can be related to acute myocardial infarction, can be related to myocardial ischemia, which can be caused by reduced myocardial perfusion or increased myocardial demand. So in case if we are talking about reduced myocardial perfusion, it is all those vascular things that may occur which decreases flow towards the myocardium. Coronary arterial spasm, coronary embolism, coronary artery dissection, sustained bradyarrhythmia, hypotension, respiratory failure, or severe anemia. In the same way, increased myocardial oxygen demand, sustained tachycardia, or severe systemic hypertension. Cardiac conditions like heart failure, myocarditis, cardiomyopathy, Takotsubo syndrome, recent coronary artery vascularization, catheter ablation, defibrillation, cardiac contusion. These are all other cardiac conditions which may cause myocardial injury. Of course, the systemic conditions like sepsis, chronic kidney disease, pulmonary embolism, use of chemotherapeutic drugs, critical illnesses, and strenuous exercise. Another question to the students: what are contraindications to thrombolysis? As Harrison mentions, the clear contraindications of using fibrinolytic agents are cerebral hemorrhage that may have occurred any point of time in life, non-hemorrhagic strokes, and other cerebrovascular event within last 1 year. Marked hypertension with a systolic blood pressure greater than 180 or a diastolic blood pressure greater than 110 at the time of presentation. The use of nitroglycerin or labetalol to bring the pressure down for an effective thrombolysis is recommended. Suspicion of aortic dissection is an absolute contraindication of thrombolysis, and active internal bleeding excluding menses. Relative contraindications are use of anticoagulation with INR greater than 2, recent major surgery in last 2 weeks, prolonged CPR which is defined as greater than 10 minutes of CPR, presence of bleeding diastasis, pregnancy, hemorrhagic ophthalmic complications like vitreous hemorrhage in proliferative diabetic retinopathy, active peptic ulcer disease, and severe hypertension which, though adequately controlled, may be a relative contraindication to thrombolysis. Now, failure of reperfusion is a major entity in which you may have to do a rescue PCI. So, what are the failures of reperfusion? How do you define a failure of reperfusion? So, after 90 minutes of administration of TPA, if there is no relief of chest pain, failure of reperfusion, no resolution of STE or rather increase of ST elevation in the myocardium, this thing, it is again failure. Presence of or absence of reperfusion arrhythmias to be noted during TPA therapy again denotes a reperfusion, or recurrence of chest pain with fresh changes in the ECG because of distal embolization of the thrombus also represents a failure of thrombolytic therapy, and the person may have to undergo a rescue PCI. This I wanted to bring to notice of the medic and the paramedical staff who will not only analyze the ECG rhythm, but also while staging it, you have to tell the cardiologist oblique the person who is going to handle the cases at a CHC oblique a tertiary care center as to what exactly is the clinical classification of the MI, how stable or decompensated is the patient. So stage 1, there is definitely a chest discomfort, there is RWMA, there is rise of cardiac troponins, there is a changes in the ECG, but these patients don't have any features of heart failure so far. In stage 2, there is a heart failure which includes that there is a S3 gallop and there is a pulmonary venous congestion which is barely heard, weight rails in the lower half of the lungs. Stage 3 is severe failure. Now this lower half of the lungs is as far as the posterior side of the auscultatory lung fields are concerned. So in stage 3 what happens? There is a severe failure of the heart, the rail will be heard till the apices of the heart. Stage 4, this occurs as a progressive measure to the stage 3 and the person is in cardiogenic shock. So I also wanted to bring to the notice the heart score. While you encounter a patient of chest pain, this is a very easy score to remember because the pain is occurring for heart. Chest pain, risk stratification. So how do you score it? Heart includes history, ECG changes, age, risk factors and elevation of cardiac troponins. The history, whether it is slightly suspicious, moderately suspicious, highly suspicious, ECG in the same way, age, risk factors, whether it is greater than 3, greater than 2, troponins, whether it is 3 times the upper limit of normal, 2 times the upper limit of normal, and then you add all these factors up and it gives you a heart score. If it is less than 4, consider directly discharging from the ED. From 4 to 6, further workup is required, medical optimization of therapy. Greater than 6, you have to send the patient to an immediate PCI, early PCI. So these are not a very hard and fast. Over here, if you see the patient, the index patient of ours, he never had a very high heart score. He had a history which was very moderately suspicious and an ECG which had a non-specific repolarization disturbance. So he had a heart score of only 3. So he would have gone home. However, because of the high index of suspicion that we maintained throughout, he underwent a thrombolysis. This again is a score which should not be undermined while dealing with ST elevations MI. Over here, the history, examination and presentation is scored from 0 to 14, and this translates to a risk score from 0 to 8 and greater than 8, which shows the odds ratio of death by in next 30 days. So if you see, if the TMI risk score in ST elevation is greater than 8, the chances of death just goes 9 to 10 times more than when the risk scores are 0. That will be all. Now I'll be ending my presentation. If any questions are there, you may write it in the chat box. So Abhimanyu Singh writes, sir, in this case, patient developed atrial flutter even though the ST elevations was decreasing. Was it a failure of thrombolysis? No, Abhimanyu, it was not a failure of thrombolysis. Look, when we are dealing with myocardial infarction, Hana, it is a very easy diagnosis. Hana, you have done the ECG, you have done the cardiac troponins. Cardiac troponins have turned out to be positive. The ECG shows ST elevation, and now just giving a thrombolysis does not absolve your responsibility. Thrombolysis is just the beginning of the treatment. When you give thrombolytics, when you give tenecteplase, you have just started the treatment. Now what happens is, the myocardium that has got infarcted, it has become a very bad substrate now. It has become an arrhythmogenic substrate now. So what happens when there is a reperfusion from this? It gives to electrical disturbances which may manifest in terms of ventricular fibrillation, ventricular tachycardia, pulseless electrical activity, or in this case, because it is the right coronary artery, it supplies the SA node, it supplies the AV node, it supplies the whole of the left ventricle, it goes to the inferior side of the heart where it divides into PDA and PLV branches. And so over here what happened, probably there was a embolus in the sinoatrial node, and this sinoatrial node became defunct, so other pacemakers of the heart took over, and that is how he went into a atrial flutter. And because he had a atrial flutter or a fibrillation and with hypotension, there were not much of a pharmacotherapy that we could have offered him. Every pharmacotherapy, except for digoxin, every pharmacotherapy had its own risk. So trying using aminodarone would have been not a very great idea, especially when aminodarone is known to cause hypotension and bradycardia. With a heart rate of already around 50, we could not have sustained it. We could not have sustained it for more. So what we did is, we took him up for a DC cardioversion, and after cardioversion, let me tell you, the the systolic blood pressure rose at least by 10 millimeters of mercury. That is how it is. And yes, so any more questions? I am waiting for some more questions to be there. So in inferior wall MIs, in which you find ST elevation in lead 3 greater than ST elevation in lead 2 with a concomitant depression in lead V2, Hana, please do a right-sided chest lead, as I have told you. The V1 on the fourth intercostal region, V2 over here just in front of it, and then V3, V4, V5, V6, you go like that, and you take a right-sided lead. Right-sided lead shows an ST elevation greater than 1. Of course, the patient is in RVMI. Do not panic in RVMI. In RVMI, the patient will go into hypotension. Firstly, the answer to that is fluid. Hana, please load this patient with fluid. Try to achieve a urine output of 0.5 ml per kg per hour. If you have achieved that, patient is doing very well. If you haven't achieved that, please do add on noradrenaline just to keep the patient high. Again, once again, let me clarify one thing. The management of myocardial infarction or the treatment of myocardial infarction, the definitive management of myocardial infarction is PCI. All whatever that we do, the loading doses, the thrombolysis, everything that we do is a bridge to PCI. The final therapy lies in getting a PCI done. So because we are a non-PCI capable center, we manage this case with thrombolysis. In next chapters or next online seminars that we are going to have, we will discuss about all the thrombolytics available. We will be discussing about all the anticoagulations available. We will be discussing about the pharmacotherapy of dual antiplatelet therapy, the triple antiplatelet therapy, why it fell into disrepute, why we are coming back again. Anna, we'll be discussing various drugs in the next seminar that we are going to have. Thank you so much, everybody, for joining in, and goodbye. I'm signing out.